like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi everyone, and welcome to the May 2018 edition of the PRS Journal Club podcast. My name is Francesco Egro, PRS Resident Ambassador from the University of Pittsburgh Medical Center. And as always, I'm joined by my co-resident ambassadors, Ira Savetsky from NYU and Nicole Phillips from the Harvard Plastic Surgery Program. Today we have the great honor of being joined by Dr. Vu Nguyen as our guest moderator. Dr. Nguyen is an assistant professor and residency program director at the University of Pittsburgh. Thank you so much, Dr. Nguyen, for joining us this PRS Journal Club podcast.
My pleasure.
Before we dive into our discussion, I want to remind everyone that this article, along all of the articles that are discussed on our podcast, can be read for free on prsjournal.com. The article we'll be discussing today is entitled Mechanical versus Hand-Sewn Venous Anastomosis in Free Flap Reconstruction, a systematic review and meta-analysis by Vu et al. I think this is a great paper because the authors attempt to answer a question that we all have, which is whether superior outcomes can be obtained with a coupling device compared to the traditional hand-sewn venous anastomosis. This is an important question because venous complications are the primary reason for flap loss, and therefore the quality and reliability of microvascular anastomosis are essential. The authors used the PRISMA methodology to perform a systematic review and meta-analysis, having two independent investigators reviewing all of the English and Chinese literature. And the studies were included if they were clinical studies and comparative studies, if they grouped patients based on venous anastomosis technique, if the arterial anastomosis was performed with the hand-sewn technique, and if a definitive outcome of venous anastomotic time, postoperative complications, or final flap necrosis was reported. And also studies were excluded if they didn't have control groups, if the results were ambiguous, if the articles were by the same author or had identical data, and if vasculoplasties of the donor or recipient site were performed. Ultimately, a total of 12 studies were selected, 7 studies in Chinese and 5 studies in English. 11 out of 12 of the studies were retrospective and only 1 was prospective. A total of 3,788 flaps were involved in this review, 56% of which were hand-sewn and 44% were performed using a coupler, most commonly between 2 mm and 3.5 mm in diameter. The main indications were head and neck and breast defects, and most common flaps employed were ALT in 29% of cases, followed by TRAM 24%, fibula 18%, deep or superficial inferior epigastric perforator flaps in 11%, and radioforum flaps in 10% of cases. The average vein anastomotic time was significantly lower when using a coupler with an average of 4.9 minutes for couplers and 16.4 minutes for hand-sewn technique. The overall complication rate was significantly reduced by 40% using a coupler from 4.2% with the hand-sewn technique to 1.8% using a coupler. The rate of flap failure was also significantly lower when using a coupler with an average of 1.1% for couplers and 2% for hand-sewn technique. The authors also performed a subgroup analysis and showed that coupler technique compared to hand-sewn anastomosis leads to a significantly reduced flap failure rate in head and neck reconstruction, whereas this difference was not found in breast reconstruction. Lastly, coupler technique compared to hand-sewn anastomosis leads to a significantly reduced venous complication rate in both head and neck and breast reconstruction. So I thought this was a really well-conducted study. It had a very strong methodology, a very solid statistical analysis, and was extremely well presented. I was surprised of such a significant difference in outcomes between coupler anastomosis and hand-sewn technique. And I would like to commend the authors for using the PRISMA methodology, which is an evidence-based minimum set of items for reporting in systematic reviews and meta-analysis, which truthfully in the literature nowadays you don't really see it as frequently as we should. However, any meta-analysis is unfortunately as good as the original studies, and most of the identified studies are retrospective in nature, and ideally when performing a meta-analysis, you want to include prospective cohort studies and randomized trials. For this reason, I think that this study gives us an idea of the benefits of coupler anastomosis, but not definitive in my opinion. I have a question for you, Dr. Nguyen. How much do you think operative variability affects each technique, and would you agree that the use of venous coupler minimizes surgical error?
I think looking at this issue, just like you had said, there's the broader issue of percentages and numbers, which this meta-analysis gets at in regards to the improvement in regards to the viability of the anastomosis and flap failure. I think on an individual level, if you talk to microsurgeons, undoubtedly people would say that the venous coupler has taken what is the most difficult portion in microsurgery, which is the venous anastomosis, and almost made it the easiest portion. So from a point of view of time, I think most of us have the direct experience that it has saved us in time, and that is likely extrapolated through its reliability in regards to affecting flap failure rates. So I think it's been a tremendous improvement and a revolution in regards to microsurgery. In regards to your question about specifically operator variability, there's always operator variability, but utilizing a device which has some consistency with it takes out an element of that operator variability, and in fact may expand the ability to do microsurgery to a broader spectrum of both practitioners and patients.
Thank you, Dr. Nguyen. Absolutely, and I can only hope that they managed to invent some similar device for arterial anastomosis. I mean, we had, for our listeners, we had the PRS Grand Rounds with Dr. Lin, and he showed us some fascinating new technologies that will come in the future. What were your thoughts, Nikki, about the paper?
Well, first, I love that you brought up Dr. Lin's, discussion of a possible arterial coupler from our recent Grand Rounds. I was thinking about that a lot as I was reading through this paper. One of the questions that I had while I was looking at this data was, in my experience, which of course is relatively limited, we have turned to hand-sewn anastomoses basically when we think we can't use a coupler. So when the vein is really small, when the vessel is very friable, like for instance, if they've had prior radiation. And so I was wondering if these were already situations in which this is potentially prone to complication based on what we were looking at and the decisions we were making in terms of doing a hand-sewn versus a coupler anastomosis. And so my question, Dr. Nguyen, was, do you think this is potentially a factor here? Is this something that we should have looked at more closely? Or are you pretty convinced that, the coupler really is the answer and there's a clear divide between hand-sewn anastomoses and coupler anastomoses?
I think if you look at the standard situation, it's clear that the coupler provides speed, reliability, and also it can provide a certain level of comfort. And that's no small thing in microsurgery or in any surgical field, particularly plastic surgery. There was the old adage that a microsurgeon had X number of free flaps within their armamentarium due to issues of fatigue and stress. And so any way that you can help manage that physical stress can not only make your individual outcomes better. Again, if you are under a less stressful situation, you can likely perform better to do that microanastomoses, but also increase the overall number of patients and microanastomoses that you may do over a career. You had a number of questions there. Remind me again which one we're addressing here.
I was just sort of talking about the situation in which, potentially we're looking at a very small vessel or a very friable vessel. Those are the times that I have seen my attendings turn to a hand-sewn versus a coupler anastomosis. And so I was wondering if that was potentially a complicating factor, if that was something we should look at in another study.
Probably the biggest drawback of utilizing the coupler is the lack of experience that a generation of people are accumulating without doing frequent venous anastomoses. And then you're being asked to do those venous anastomoses under more difficult conditions. Like you said, small vessels, end-side anastomoses, radiated fields, things like that. So that's an interesting phenomenon. You could also argue that in certain situations, for example, like a small anastomosis or a radiated field, that the coupler may even be more warranted because, again, it can potentially help in those situations where the situation's more stressful. But there will always be situations where you need to do a hand-sewn venous anastomosis in regards to particularly end-side, or situations where the coupling device just cannot perform in that situation. It can't reach. It doesn't conform correctly to the recipient site, or situations where you don't have a coupler, or a coupler is the device actually just malfunctions or doesn't work. So there is the concern that we're getting away from routinely doing venous anastomoses and being facile with that difficult portion of the operation.
I think that's a great point. There's one attending here who sort of makes a point of teaching us to do the hand-sewn venous anastomoses for that very reason, that he wants us to not become too reliant on the couplers. So I think that's a great point. Ira, what were your thoughts about this study?
I really enjoyed the discussion happening, and I agree with everything that was said. I thought this was a really interesting study, and sort of what we already stated, anything that we could do to make our time in the operating room more efficient and decrease postoperative complications is always obviously very appealing. Similarly, like you guys here at NYU, most of the times the attendings do prefer a coupler when possible. We do have some attendings who do prefer to hand sew, and I think it's large part of how they were trained, and also, again, like Nikki said, from an educational perspective, I think it's important. Our chairman, Dr. Rodriguez, who trained at Changgung, where they typically, from what I understand, do a lot of hand sewn for venous anastomosis, he makes a point to spend time with us and teach us to do it. I believe over there, for example, probably similarly in other places international, it's probably related to costs. I think up front there's a higher cost for using a coupler. Now, the paper does discuss potential cost savings by potentially reducing operative time and postoperative explorations. The paper reports, as Francesco had mentioned, about a 40% decrease in the incidence of venous complications. I think there is a learning curve, just like anything else, which we had spoke about, and the learning curve is likely steeper for hand-sewn versus a coupler. But I do think once someone is comfortable and proficient, venous complications should be similar in experienced hands, and similarly the take-back rate. Dr. Nguyen, what are your thoughts specifically as it relates to cost? Do you think there is a true cost savings at the end of the day if you're using a coupler?
Just like you said, the initial upfront cost in regards to the device and the actual disposable materials is certainly higher than suture and hand sewing it. But then the latter cost in regards to time savings, and if there is a take back, obviously any complication really significantly increase the cost factor. Also, as was mentioned before, and really not something to be overshadowed, is the opportunity cost in regards to the ability to be comfortable and to have less stress and have less physical manifestations from doing microsurgery. I'm kind of midway in my career, and I'm already dealing with some of the physical outcomes of either surgery or potentially even microsurgery. So those things cannot be overshadowed in regards to, there is a silent phenomenon of surgeons, and particularly plastic surgeons, having cervical, thoracic, neck problems, and what we can do to minimize those things. So for our residents, we try to become very cognizant about being comfortable when you operate, whether it's a standard operation or a microsurgical flap. Because in the end, if you are comfortable, that means you will perform well and reduce your risk of complications, because the complications are the patient's and not your own, except for, again, save these physical issues that could manifest later on.
Those are really great points. You had mentioned that, there's going to be sort of a generational gap from people feeling very comfortable sewing veins by hand. So what are your thoughts from an educational perspective? Obviously, you're the program residency director. What are your thoughts about how the residents these days can become comfortable and proficient in hand-sewn anastomosis?
That's coupled with, a whole big issue in regards to how do we educate a new generation of surgeons and potentially not educate them at the cost of patients. And so ideally, one answer is with surgical simulation, having a microsurgical lab, having both low fidelity and high fidelity models for you to be able to be facile on a venous anastomosis before you're doing that on a standard microsurgical case for a patient, or certainly before you're doing that in a challenging situation. So I think that would ideally address some of the complaints from the old guard saying that, you're going to lose your venous anastomosis microsurgical skills.
That's awesome, Dr. Nguyen. Thank you so much for all of that. Out of curiosity, you mentioned simulation models. What do you guys do at NYU and at Harvard? Do you guys have a microsurgery lab? How frequently do you do it?
So when we're fourth years, when we're really diving into our plastic surgery years, at the beginning of the year, we had a rat lab, microsurgery rat lab, where we would practice our microsurgical techniques, and we did do veins as well. It's like anything else. Simulation is great, and it's really beneficial, as are cadaveric dissections, and as a resident, it's super beneficial. But the problem is finding time, not just on our end, but also for our great attendings to dedicate time as well. So I think that's always a challenge. But we try to do as much as possible, but I would say, at the beginning of our fourth year, we really have a week basically of just doing microsurgery on rats, which I think is very helpful. What about you, Nikki?
That's awesome that you guys get that dedicated week. We do not have a dedicated week like that, but we do have lots of opportunities for work, both in a rat lab as well as we have a actually a 24-hour simulation center that's open here that we can access anytime, and that's using just materials that they've set up for us there to try and simulate what it's like. I would echo your sentiment that simulation is a wonderful adjunct, but really, until you're in the operating room, people watching you, patients breathing. It's just such a different situation with a moving field, and I think it really is all about experience and great teachers. We also start around in our 4th year getting under the microscope quite a lot, and so by the time you're at my point where you're looking at graduation in just a few months, feel very comfortable under the scope, which is great.
That's awesome. I'll comment for Pittsburgh. We have a microsurgery lab using a chicken leg twice a year, but then we have an open lab throughout the year. That has definitely been very, very helpful. With that, I'll just like to thank everyone. I really enjoyed today's podcast, and I think we'll end our discussion of this article. Thank you, everyone, for joining us. If you like this podcast, please feel free to share it with your friends and rate us in the iTunes store. Also, remember to tune in to the other 2 articles we'll be discussing on this month's podcast. And finally, please join us this month for our monthly journal club on Facebook. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not yet done so already. And it is there where our monthly journal club takes place. Once again, Dr. Nguyen, it was an honor having you on our podcast today. Thank you so much for joining us.
Thank you for involving me.